Good evening, everyone. Greetings from Bangalore Medical College and Research Institute. I'm Dr. Bhargavi Sanket. At the outset, I would like to thank the Ballari Anesthesia Society as well as the VAA group, Ballari Medical College and Research Center. I'm honored to be part of this academic meet. Today, we will be discussing about the anesthetic considerations in bariatric surgery. So, what is bariatrics? Bariatrics is a branch of medicine which focuses on the causes, prevention, and the treatment of obesity. What is obesity? It is a chronic complex disease defined by excessive fat deposits which can impair the health with increased risk of type 2 diabetes mellitus, cardiovascular, cerebrovascular, reproductive health, and also certain types of cancers. Why is it important to study about this is because of its epidemic status and its double Zamaka effect. It affects not only adults but also the adolescents and the children, and it not only a burden of the high income countries but also on the mid as well as the low income countries. So let us discuss about obesity in detail. Classification. Obesity is classified depending upon the body mass index, which is given by the weight divided by the square of the height. The normal is less than 25, and as the BMI increases above 25, it is classified as overweight, class 1, class 2, and class 3 obesity with increasing mortality and morbidity. The types of obesity include central obesity or the apple shaped obesity and the peripheral obesity or the pear shaped obesity. In central obesity, the fat accumulation is mostly seen above the waistline, around the important organs, and hence there is increased likelihood of metabolic response with the form of increased levels of tumor necrosis factor, interleukin 1, CRPs, causing increased development of hypertension, diabetes, and hypercholesterolemia. This is classified as the metabolic syndrome, and this is seen most commonly with the male gender. Central obesity can be diagnosed with a waist to hip ratio of more than 0.9 in females or more than 1 in males, a waist circumference of more than 88 centimeters in females or more than 102 centimeters in males, or a waist to height ratio of more than 0.55. Treatment of obesity includes lifestyle modifications like diet and exercise, education and psychological counseling, medical management, and surgical management, which has been around since 1954. Today, multiple surgical options with even laparoscopic types have been introduced. The indications for surgery include adults with a BMI of more than 35 kg per meter square with or without comorbidities, or a BMI of more than 30 kg per meter square with type 2 diabetes mellitus and no improvement with the non-surgical methods. In children and adolescents, the BMI based on the percentile is taken. In the Asian population, a BMI of lower cutoff, that is 27.5 kg per meter square, is included. The contraindications of surgery include extremes of age, severe illness, alcohol or drug abuse, and also unwilling to cooperate with the dietary and lifestyle modifications postoperatively. The different surgical options can be classified into malabsorptive, restrictive, or combination. In malabsorptive, there is decreased absorptive surface for nutrient absorption. In restrictive, which is a more popular methodology, there is decrease in the size of the gastric gland. That is, a pouch is created which increases the satiety and decreased intake of food. The popular among this is the sleeve gastrectomy, where a semicircular section of the stomach is excised. It is irreversible but found to be promising. The promising surgeries actually include the Roux-en-Y gastric bypass or the pancreaticobiliary diversion with duodenal switch, where a proximal gastric pouch is created, and this is anastomosed to the distal jejunum or ileum. The stomach as well as the duodenum and ileum is anastomosed to this Roux-en-Y loop to an end-to-side anastomosis. Though there is risk of surgical complications, they have shown better results in terms of weight loss and diabetic management. Though there are multiple benefits with bariatric surgery like diabetic management, reduction of the BP, and prevents health disease and obstructive sleep apnea, lowers cholesterol, not any surgery is without complications. Obstetric surgery itself forms an intermediate to high risk surgery, and the patient risk can be quantified through the mortality risk score. It's a 5-point risk score with BMI of more than 50 kg per meter squared, male gender, age more than 45 years, hypertension, and prevalence of risk factors like pulmonary embolism, like previous history of pulmonary embolism, pulmonary hypertension, obstructive sleep apnea as well as presence of an IV filter. With increasing score, there is increasing risk of mortality. So preoperative evaluation involves recording of the total body weight, height, calculation of the BMI, and along with this ideal body weight and the lean body weight with the formulae which has been mentioned for the calculation of the anesthetic drugs. Obesity is a multi-system, multi-organ disease, but in terms of anesthetic preoperative purview, the cardiovascular risk assessment, venothrombotic risk assessment, obstructive sleep apnea screening, and malignancy screening are vital. So pathologies associated with the cardiovascular system include LV and RV failure, arrhythmias like atrial fibrillation, supraventricular tachycardia, and SA nodal dysfunction causing bradyarrhythmias, pulmonary hypertension due to repeated episodes of hypoxia and hypercarbia leading to right heart failure, cardiomyopathy due to cardiac remodeling causing both LV and RV dysfunction, and ischemic heart disease. So evaluation of all these pathologies along with coexisting comorbidities which form part of the metabolic syndrome is absolutely vital. Diagnosis of exertional dyspnea may be tricky because they may have a low exertional dyspnea not only because of the sheer weight or also because of multiple musculoskeletal disorders. Examination of the vitals may also prove difficult because palpation of pulses may be difficult, palpation of the lymph glands may be difficult, a JVP may not be visualized because of a short, thick neck, auscultation of heart sounds and breath sounds may also be muffled. So investigations play a vital role with a basic of at least an ECG and a chest X-ray and echocardiogram. The further cardiopulmonary testing depends upon the revised cardiac risk index score with a dobutamine stress test, echocardiography, or a radionuclide ventriculography if warranted. Diagnosis of obstructive sleep apnea is especially important when the BMI is more than 35 kg per meter squared. Diagnosis of obesity hyperventilation syndrome, where there is hypercapnia along with the high BMI and OSA, is important because these patients are especially sensitive to the depressant actions of the anesthetic drugs and are associated with postoperative respiratory failure and prolonged stay in the ICU or the HDU. They come with symptoms of exertional dyspnea along with early morning headache and an ECG showing right ventricular hypertrophy. The screening tests include the stop bank questionnaire, which include 8 points like history of snoring, daytime somnolence, observed apnea during sleep, high blood pressure, a BMI of more than 35 kg per meter squared, age of more than 50 years, a neck circumference of more than 40, or a male gender. A score of more than 4 has highly sensitive and more than 6 is highly specific for obstructive sleep apnea. Definitive screening involves polysomnography, which is quantified through the apnea-hypopnea index. A score of more than 30 is a high risk of obstructive sleep apnea. Monitoring of overnight oximetry along with pulmonary function testing is warranted because obesity is associated with reduced total lung capacity, expirated reserve volume, as well as the functional residual capacity. A forced vital capacity of less than 3 and an FEV1 at 1 second of less than 1.5 liters should be followed up with a room air ABG. So optimization of these patients include a breathing exercise, incentive spirometry, and more importantly is a pre-op CPAP because studies have shown that patients who are compliant with a pre-op CPAP and show symptomatic relief are less associated with postoperative respiratory failure and ventilatory complications, and also they have a shorter duration of ICU stay and they can also be considered for daycare surgeries. Screening for venothrombotic episodes is important because obesity itself is a prothrombotic state because of immobility causing venous stasis, increased abdominal pressures again causing venostasis, and also increased circulating clotting factors and also polycythemia. They can present with myocardial infarction, stroke, and also other venothrombotic episodes. Risk factors include a BMI of more than 30, geriatric age, smoking history, OCP use, and prolonged surgeries. So prevention is better with early mobilization planning for the postoperative period, use of compression stockings, pneumatic sequential compression devices, and pharmacological prophylaxis with either unfractionated heparin or low molecular weight heparin with the dosing dependent on the ideal body weight and preferably a BD dosing. Malignancy screening is again important to avoid any surprises in the postoperative period. Obesity is a risk factor of difficult airway. So the mnemonic moans, what we have studied, is associated with difficult mask ventilation, and every alphabet has some correspondence with obesity. There may be a difficult mask seal because of a beard, or also fat folds around the mouth or abnormal facies. Obesity itself, a geriatric age, being a dentulous, and also stiff lungs because of a suprasternal or parasternal or a posterior cervical pad of fat, or even excessive tissue in the lateral pharyngeal walls can contribute to the stiff lungs, along with low compliance, contributing for a difficult mask ventilation. The predictors of difficult laryngoscopy and intubation is given by the Lemon mnemonic, and I would like to point out that neck mobility plays an important role here, because obese patients are associated with short, thick neck, and also neck circumference of more than 40 centimeters are associated with a 5% probability, or neck circumference of more than 60 centimeters are associated with a 33% probability of difficult airway. Recording of a pretracheal adipose tissue using ultrasound, and the values show more than 2.5 centimeters at the level of vocal cords is again an indicator of difficult intubation. So to sum up the preoperative investigations, I would like to especially point out to the endocrine evaluation here, that is the thyroid function test and the prothrombin test, thyroid parathyroid hormone levels. A nutrition evaluation is especially important with patients who are on orlistat, because they are associated with vitamin A, D, E, K, that's the fat soluble vitamins deficiency, which must be evaluated. Use of a liver shrinking diet has been advised, that is a low calorie, high protein diet for at least 2 to 8 weeks preoperatively. It helps in shrinking the liver so that there is improvement in the laparoscopic vision. It can also be helpful for the anesthetist in improving the laryngoscopic views, better control of diabetes and weight loss. Along with that, smoking cessation and alcohol and substance use cessation is of vital importance to avoid ulcers, especially at the anastomotic sites. Continue beta blockers and statins, follow the hospital diabetic regimen, continue thyroid medication, and optimize the nutritional status. Preoperative sedatives are especially avoided with OSA patients. There is a huge list of what equipment must be in ready for obstetric surgery patients, but especially for anesthetic relevance are the large BP cuffs for accurate BP measurement, use of compression stockings for DVT prophylaxis, ABG machines, and also CPAP or HFNC machines for both pre-op and post-op oxygen therapy. Operation theater equipment include a bariatric operating table which can incorporate the patient, along with suitable attachments for the leg supports for lithotomy position, and also the shoulder and foot supports. Padding for pressure points using the gel pads, wide strapping of velcros with securing of the patient to the operating table, use of ramping devices, a hover mattress to transfer the patient from the bed to the operation theater, an anesthesia ventilator which is capable of delivering PEEP along with good tidal volumes, a portable ultrasound machine for either a regional block or for invasive IV access, or also for airway ultrasound. Proper sizes of spinal and epidural needles along with long arterial lines if femoral access is necessary. Here I would like to point out the importance of multidisciplinary involvement. Discussion of with a team of surgeons, anesthetists, ICU management, nursing staff, psychiatric department for counseling, and also nutritional team to advise on the preoperative and postoperative diet is very important. So planning of the airway management is again of vital importance, because obese patients come to the category of difficult mask ventilation, difficult laryngoscopy intubation, also difficult surgical access. However, active pursuit of methods to deliver a supplemental oxygen throughout the process of airway management must be continued. There should be a plan formulated for either an awake intubation or intubation after induction of general anesthesia, non-invasive or invasive methods, use of fiber optic laryngoscopy or a video-assisted laryngoscopy, either preservation or ablation of spontaneous ventilation. So depending upon the anesthetic plan, the difficult airway cart must be stopped up with a different paraphernalia. NPO guidelines as per the ISA 2020 guidelines for obese patients tell that even though obese patients are at higher risk of aspiration because of higher resting gastric volume with lower gastric pH in spite of similar fasting duration as the non-obese. And the similar guidelines must be followed, that is 2 hours for liquids and 6 hours for solids, combined with aspiration prophylaxis on the night before and the morning of surgery with use of H2 blockers, proton pump inhibitors along with prokinetics. A gastric ultrasound can be used as a screening tool in the right lateral decubitus position to see if the resting gastric volume is more than 1.5 ml per kg or presence of solid components which can contribute to aspiration risk. Monitoring use of standard ASA monitors along with urine output and temperature monitoring. A TOF monitoring for assaying the neuromuscular blockade use of BIS monitoring to titrate the anesthetic doses. Invasive arterial monitoring, in case appropriate size BP cuff is not available, it can also help with ABG drawing and also with advanced hemodynamic monitoring for goal-directed therapy. Use of transesophageal echo for assessing the cardiac status. A CVP line can be secured if peripheral lines are not adequate, which can also help with goal-directed therapy. Self-positioning is important to avoid unnecessary manual positioning of the patient. 25-degree head elevated position improves the ventilatory mechanics, opens the airway. A ramp-up position for intubation where the external auditory meatus is in line with the sternum is recommended for intubation with use of either folded blankets, inflatable pillows, or pre-manufactured elevation pillows. This has been showed with improved success of intubation. Padding of pressure parts is again important. Continued oxygen delivery through pre-oxygenation or paraoxygenation during the process of intubation to prolong the safe apnea. It's been found that the incidence of desaturation is directly proportional to the level of oxygenation attained before the patient becomes apneic. So methods including 100% oxygen through a well-fitted mask for 3 minutes or 4 vital capacity breaths with 100% oxygen for 3 minutes. Nasal oxygen delivery during efforts of tube placement or HFNO must be used. After the patient has lost consciousness, standard oxygenation with a two-hand ventilation method with use of oral or a nasal airway. Continued nasal oxygen or a CPAP. Pressure support ventilation with 10 centimeters of water of CPAP. Thrive, oxyscopes or oxygen delivery with use of a nasopharyngeal airway or a buccal RAE tube during the efforts of intubation can be employed. Induction with rapid onset short-acting drugs. This will be dealt in detail in the next talk. Intubation with an endotracheal tube is a gold standard for securing the airway for obesity surgeries, and the use of an ideal body weight is used for calculating the ET tube size. Depending upon the plan which has been formulated, intubation is done. If an awake intubation is planned, then use of airway blocks to anesthetize the airway along with spraying of the local anesthetic can be employed. Ultrasound marking of the cricothyroid membrane can be done preoperatively in case of anticipated difficult surgical airway access. After airway has been secured, placement of the rising for gastric decompression along with gastric tube placement for surgical help. A pressure control or a volume control ventilation can be utilized, but an inverse ratio ventilation is preferred to prevent atelectasis. A tidal volume of 6 to 8 ml per kg can be maintained depending upon the ideal body weight. A PEEP of 5 to 7 centimeters of water is preferred, but it has to be individualized. Recruitment measure are especially used immediately after intubation to prevent the pre-oxygenation and atelectasis, increasing the inspiratory pressures to 55 centimeters of water for seconds with 10 centimeters of PEEP followed by normal ventilatory settings. A peak airway pressure must be maintained below 36 to 40 centimeters of water. A reverse Trendelenburg position can be used as and when the surgeon is compliant with it in order to improve the ventilatory mechanics and improve the compliance. So intraoperative anesthetic dose, inhalation and IV will again be covered in the next talk. Multimodal opioid sparing analgesia must be used. NSAIDs are not preferred because of the risk of renal failure and development of gastric ulcers. However, paracetamol, ketamine, clonidine, use of short-acting opioids like sufentanil, remifentanil, gabapentin, melatonin, and pregabalin have also shown promising results. Surgical site infiltration has been promising. Interperitoneal installation of bupivacaine is also being used. Use of ultrasound guided blocks like subcostal tap block, rectus sheath block, and erector spinal block have been recommended. Neuraxial epidural blocks under ultrasound guidance, either for anatomical landmark marking or under live guidance, can also be used. Placement of a 5 centimeter catheter inside the epidural space is recommended because of displacement of the catheter during positioning and movement of the patient. The lean body weight can be used to calculate the local anesthetic dose, but still there may be unpredictable spread of the local anesthetic because of fat infiltration in the epidural space. Hence, multimodal analgesia methods are employed. Obese patients poorly tolerate both hypovolemia as well as hypovolemia. Hence, balanced salt solutions with goal-directed therapy while checking for fluid responsiveness must be maintained. During extubation, the difficult airway cart must be kept ready, and because there may be difficult mask ventilation or intubation, the patient should be extubated only when fully awake and obeying commands. Recruitment of the lung must be done with oxygen supplementation through the ET tube during extubation, along with use of an airway exchange catheter or fiber optic before extubation. A continuation of CPAP or HFNC post extubation is recommended. So to sum it up, low lung recruitment before extubation, 30-degree head up, adequate tidal volumes being generated, a TOF count of 4. Succumedex is again suggested in the doses of 2 mg per kg in case of inadequate neuromuscular reversal. Post extubation, use of a CPAP, BiPAP, or a HFNO is recommended with a low threshold for these oxygen therapy methods. Recovery is continued in the HD or ICU, especially when the mortality risk score is 4 to 5. Else, they can be managed in the PACU and then shifted to the surgical ward. Nursed in an upright position, low threshold for oxygen use, prophylaxis for thromboembolism, early feeding, hospital diabetic management. And here I would like to stress upon the prophylaxis for postoperative nausea, vomiting with an opioid-free regimen and a true drug combination with the use of steroids along with either ondansetron, cyclizine, or progloprazine. Postoperative complications include rhabdomyolysis because of tissue necrosis, which can be diagnosed with the rising serum creatinine and kinase levels, should be treated with fluids as well as urine alkalization. Cardiac complications like myocardial infarction and arrhythmias are again common, especially with patients with metabolic syndrome. Pulmonary complications, especially patients with obstructive sleep apnea is common. They should have a low threshold for giving oxygen therapy either through HFNO or nasal CPAP. Surgical complications like dumping syndrome, bleeding, and anastomotic leak must also be watched out for. Opioid-free anesthesia is especially recommended for obstructive sleep apnea patients to reduce the incidence of postoperative ventilator depression and also reduced PO1B. The Friedberg's triad is recommended, that is, measure the brain, preempt the brain, and emetic drugs abstain. So these are the pictures of sleeve gastrectomy which was conducted in our center. Positioning, HFNC for pre-oxygenation, intubation and gastric tube placement, and intraoperative ventilation. Thank you. I'd like to add that all the material has been taken from these 3 protocols which have been mentioned. Thank you for your patience.